Now regarding these guidelines for the management of adult aplastic anemia, combination, and it's important that we keep in mind which is this gamma criteria. This is referred to a lot of other studies also severe. Then also the recommendation that whenever most of the cases of adult aplastic are idiopathic, and there is also this will actually we will go try to go side by side with these guidelines for the this pediatric amendment to the guidelines, which also recommend some differences in the pediatric workup, and the treatment pathway is also a bit different. So when we go into the diagnostic pathway, we'll briefly touch this diagnostic workup for the pediatrics, which is slightly different. But the basic approach is the same. It's like in congenital, congenital bone marrow, inherited bone marrow failure syndromes, the approach is a bit different regarding the diagnosis, and because there will be some specific tests. Otherwise, the main approach is the same for adult. But since we have to rule out a lot of things, so the multidisciplinary team, this team, this meeting has to be. It is recommended that a multidisciplinary approach is instituted, and that there is a collaboration to develop the treatment plan. And now then for inherited aplastic anemias, we will go into detail about how we can rule out Fanconi anemia and dyskeratosis congenita. Then the key recommendations for supportive care in the immunosuppressive therapy and hematopoietic stem cell transplant, they will be dealt with in the section with the management, regarding management. Now, when we start with the definition of aplastic anemia is that it's a rare and heterogeneous disorder, and basically there is pancytopenia with the hypocellular bone marrow in the absence of an abnormal infiltrate or marrow fibrosis. So briefly, there will be pancytopenia, the cell lines will be decreased, and the bone, but this should be concurrent with pancytopenia along with the hypocellular marrow. So in this case, should be hypocellular, and then neutrophil count less than 1.5 into 10 raised to power 9. So we have these criteria for hemoglobin. And syndrome are to be taken into account. And the incidence is about 2 to 3 per million per year in Europe, but higher in East Asia. And there is a distribution with years. Pediatric children who manifest in the later age groups. But of course, we have people even between about at any age. Basically, it can be at any age, even in 30, 40, they can present with the and but most of these cases would be where it was now yeah, this has been modified, and the modified Camita criteria, this was just the simple criteria for for pancytopenia. Now, the modified Gameta criteria divides the criteria for pancytopenia into non-severe, and this divides it into non
Okay, so we were discussing about this. We were discussing about the different criteria for the modified
criteria
gamete
for
criteria,
modified
which state that
criteria,
this is either
which
severe
state that
aplastic anemia
this is either severe
or
aplastic anemia,
very severe aplastic
or
anemia or
very severe aplastic
non-severe
anemia, or
aplastic anemia.
non-severe
So in
aplastic
severe,
anemia.
we
So
have
in severe,
less than
we have like
25%
less than
several cellularity,
25% similar
and
cellularity, and
the neutrophil.
neutrophil. So in severe, we have less than 25% cellularity, and at least two of the following criteria have to be met. That is, the absolute neutrophil count is less than 0.5. The platelets are less than 20, and the absolute reticulocyte is maintained as less than 100. But now they have taken all these absolute counts. That is, the absolute neutrophil count, the absolute platelet 20, and platelet count is also less than 20. And the neutrophil count is now it varies. That is less than 0.5 for severe, and for very severe it is as low as fulfilling the criteria for severe or very severe. So we just need to remember these three criteria, and where we have ANC less than 0.5 into 10 to the power 9 per liter, and for very severe we have ANC less than 0.2 into 10 to the power 20 into 10 to the power 9 per liter. Now, patients, they commonly present with symptoms of anemia and thrombocytopenia, and symptoms are concerned, they will be mostly related to anemia and thrombocytopenia, and the NC, even if it is low, serious infections are not the early signs. And present, then we have to first of all rule out and take this careful history of a drug, occupation, and family history. So drug history, occupational history, and family history should be carefully taken in the history part, and in the general physical examination, signs of anemia and this, or any petechia, and we should rule out that hepatosplenomegaly or lymphadenopathy. They may not. They usually shouldn't. They are not there except in infections. They may be. You may see them. Then for young patients in the pediatric age group, then we need to be very vigilant about these three signs, which are for Fanconis anemia and dyskeratosis congenita. So for these three signs you have to look for are the stature, the skeletal abnormalities, especially of the thumb, and then skin hyper or hypopigmented areas. And this is like the findings tried for Fanconi anemia, and the tried for dyskeratosis congenita is the one that involves this involves mostly skeletal and stature abnormalities and skin, and this dyskeratosis congenita involves mostly skin plus mucous membranes and nails. So there is nail dystrophy, oral leukoplakia, and in the skin there is reticular skin pigmentation. And along with this, there is also this if any if you an examination of the leg lymph, even the peripheral limbs, there is lymphadenopathy, then this may indicate Emberger syndrome due to a germline CATA2 mutation. So now we have gone through the definitions for the Kamita criteria and about how we divide it into severe aplastic and then the very severe aplastic. And of course, the non-severe aplastic is just those which are not meeting the criteria for severe or non-severe. In most cases of of aplastic anemia are idiopathic, a careful drug history must be venous involvement and skeletal and sort of like limb involvement, limb abnormalities that may be there. And then, of course, multidisciplinary team should be operated, and consideration should be given expert advice on the diagnosis and management, especially in cases of inherited bone marrow failure syndromes. Now the investigations. So first we'll go the idiopathic or plastic anemia is a diagnosis of exclusion, and no single test can rely. So we have a battery of tests for this, and so they will be. We'll go into the details about the test for adults for that. Now there is a increasing recognition that inherited bone marrow failure syndromes are commoner than previously thought and may present in the following one the investigations that although the empty marrow is characteristic and a prerequisite for diagnosis. So blood count and the reticles are also there's reticulocyte and bone marrow examination. And they have mentioned here the empty marrow histology is the prerequisite. So the main, of course, we'll go into other tests that would help to rule out other diagnoses, but this primary hypocellular marrow of course, there will be pancytopenia, and usually the hemoglobin concentration and neutrophil and platelet counts are uniformly depressed in the early stages, and isolated cytopenias, particularly thrombocytopenia, may occur. Initially, of course, it's they may be that all the cell lines are uniformly depressed, or they may be that one cell line, and usually it is the platelet count that may be decreased, and the lymphocytes are usually preserved. And the presence of monocytopenia, in fact, needs further investigation to exclude the hairy cell leukemia or inherited bone marrow failure syndrome, inherited bone marrow failure due to GATA2 mutations, that is the Emberger or the monomac syndrome, in which there is monocytosis with the monocytopenia with the particularly just monocytopenia. So the monomac syndrome or the Emberger syndrome has monocytopenia. And this is and here we'll if it is present in area, if it is present in a pediatric we'll have age group, we'll have to rule out Emberger syndrome also, and of course also hairy cell leukemias in adults. So there will be pancytopenia with mostly anemia and thrombocytopenia, and even the neutrophil count will be low, but the lymphocytes are usually preserved, and the monocytes count, if there is isolated presence of monocytopenia, then we'll have to exclude this hairy cell and Emberger syndrome. Then for reticulocyte count, the reticulocytopenia, which is the which is done with automatic reticulocyte counting with the but the automatic reticulocyte counting will overestimate the count compared with the level set in the Kavita criteria for defining disease severity, which were defined on manual count. So the original Kavita criteria was defined on manual counts, and now this criteria has now been modified with from manual percentages to absolute reticulocyte levels with less than 60 as assessed by automated technologies. So initially we had this absolute reticulocyte count. They had mentioned that it should be less than 20 into 10 raised to power 9. But now because of are a bit higher, so now they have the absolute reticulocyte levels are placed at less than 60 into 10 raised to power 9. This value is also they have mentioned there was reference to a lot of studies even. So they some even mention that less than 20 and less than 60 given different and now you see the arc reduced mind that the 60 is the automated with the side. Actually, in the original Chemita criteria, they had mentioned it as 20, but now it has been modified from manual percentage to absolute reticulocyte levels less than 60 by automated technologies. Now, the blood film examination, and this will, of course, this will show anemia, but there will be more frequently macrocytosis and anisopercular and the neutrophils and normal such as hairy cells. Then in other so this is for the blood examination, and then also in the advanced cases we may even go for HPF percentage, which is measured pre-transfusion in children, and it's an important, and this is done mostly for children. This is an important prognostic factor in children since the level is often elevated in constitutional syndromes. Since HPF levels may be raised in certain cases like diamond black anemias, they have elevated HPF levels. So constitutional syndromes, they are elevated. In cases with aplastic anemia, they will see since there is decreased marrow precursors even, so then HPF levels would be decreased, and this is an important prognostic factor in these children. Peripheral blood chromosomal breakage analysis, dipoxybutane test. This is for in patients with Fanconis anemia. If patient is aged less than 50 years, then we can suspect this even Fanconis anemia, but it would also be indicated to screen older patients if Fanconi anemia is clinically suspected. That is if it if we clinically focus individuals, and it is difficult to set in. Okay, so it is difficult to set the screening, as anecdotal cases have been diagnosed in the fifth decade. So since screening patients who are transplant candidates and cytopenia and the liver disorders. They should be even aplastic anemia. And in the viral serology, not only hepatitis A, B, C, but EBV, CMV, and HIV and parvovirus B19. So even this can cause parvovirus B19 basically affects the pro-erythroblast and the erythroid precursors, but even this can lead to but even this can be like a case for hepatitis, then hepatitis ABC and HIV, then EBV and CMV also, and parvovirus B19. Parvovirus B19 is more usually associated with pure red cell aplasia, but has been reported with aplastic anemia. An anti-nuclear antibody and anti-double-stranded DNA, pancytopenia, and SLE. This is to rule out any autoimmune causes. So we'll rule out autoimmune causes. Uh, then coming to the and also another test that they mentioned here is the peripheral blood cell leukocyte. The DEP test is for Fanconi anemia, and for dyskeratosis congenita, we can look for peripheral blood leukocyte telomere length. These are emerging tests actually. They are not currently routine diagnostic, but are likely to be so within the next few years. And they are done for telomere gene mutations in classical dyskeratosis congenita, less specific in adult onset aplastic anemia with TERT mutations. So short telomeres may also occur in acquired aplastic with reduced stem cell reserve. So peripheral blood leukocyte telomere length is done. For Fanconi anemia, we have the chromosomal breakage analysis by the DEP test, and for dyskeratosis congenita, we have the peripheral blood leukocyte for the TERT mutations. And the short telomeres may occur even in dyskeratosis congenita, but also in acquired aplastic anemia with reduced stem cell reserve. So we have done mostly the cases of pediatric age group, dyskeratosis congenita and diamond black pen, and in adults we have this PNH clone, hematinic deficiency, hepatic causes, and then the viral and autoimmune. So then coming to the radiological examination, we'll go for chest X-ray and abdominal ultrasound and echo. So chest X-ray and other radiologies, they are useful because they will like bone marrow and bone scans, X-rays of the hands, forearm, and feet. Um, and they are important. They are also done for a idiopathic for inherited bone marrow failure syndromes, and high resolution CT scan of the chest is indicated for suspected dyskeratosis congenita, because in cases with dyskeratosis congenita, they may present with the pleural involvement. So for these cases, even this dyskeratosis congenita is suspected. So abnormalities or pulmonary fibrosis or any sort of and even for dyskeratosis congenita, patients may present with liver cirrhosis and pulmonary fibrosis, and there can be cardiac anomalies and renal anomalies. So these ultrasound scans, so these radiological scans and these ultrasound scans are then important basically for congenital anomalies. And then Fanconi's anemia, they have mentioned these abnormal anatomically displaced kidneys are a feature in younger patients with Fanconi's. So in dyskeratosis congenita, we have mostly pulmonary fibrosis and hepatic liver cirrhosis, and they can be ruled out in high resolution CT chest and abdominal scans. and then even renal anomalies and splenomegaly and cardiac anomalies, they can be they should be looked for. Um, and in cases with Fanconi anemia, we have abnormal or misplaced kidneys. So they could be like normal kidneys or misplaced kidneys. And then for the next generation sequencing panels, we have telomere gene complex mutations. So first we had the telomere length on peripheral blood leukocytes. So this is on peripheral blood leukocytes, the telomere length analysis was done. Now using next generation sequencing gene panels for these TERK mutations, they are done, and other inherited bone marrow failure syndromes, genetic panels for those with the with the causes of inherited bone marrow failure syndromes are then worked up. And acquired somatic mutations and are typical of myeloid malignancies to help distinguish aplastic anemia from hypercellular MDS, and or for early detection of clonal evolution of MDS. Single nucleotide polymorphism. There's these SNP arrays karyotyping is done for whole genome sex scanning to detect unbalanced chromosomal defects. So mostly if we look into this chart and compare it with how they have presented this in Hofbrand, we'll just quickly go to the various investigations. There are laboratory investigations to confirm that examination, pancytoclear and access to be there. And even regarding neutrophils, toxic granulations may be seen, and then the platelets, they do not show any they are mainly small in size, but there are no abnormal platelets or dysplastic neutrophils or blasts or any other abnormal cells on the peripheral smear. So absence of any other abnormal cells or any dysplasia on the peripheral smear with cytopenias alone. And the only fact is that the neutrophils may show toxic granulations, and red blood cells show anisocoagulopyrocytosis with macrocytosis. And then there is reticulocytopenia, and then liver function test and bone marrow and these hematinic deficiency, hepatic and hematinic deficiencies are ruled out using LFTs and these vitamin B12 and folate levels. And then for virology, we have those check for and then CMV and EBV, and then also parvovirus B19. So also the viral markers and then the autoimmune markers, they are also done. And then for so we have gone into hepatic and hematinic deficiencies and autoimmune profile and viral markers. And then in case of adults, we do the PNH clone, and in children, we can go for the HPF estimation. And then regarding the radiological examinations, we have and then of course the bone marrow examination would be there. And we'll go into the details of the bone marrow later on, but then there is also this abdominal scan and CT in chest to rule out any sort of pulmonary, cardiac, or hepatomegaly or liver cirrhosis and renal abnormalities, which are common with Fanconi anemia. So I think we'll be running out of time. So we'll join again and then complete the pediatric age group also. And regarding the specialized test, we not only go for the PNH clone, but also for the any other thing that they have mentioned is the lymphocyte analysis. Not only the leukocyte telomere length in children and Fanconi anemia depth test in children is done, but there is also then we can also go for the PNH clone. The MDS can also be ruled out by doing cytogenetics. So for deletion 5q and deletion 13q, the most common causes of MDS. So even cytogenetics on bone marrow and PNH clone on flow cytometry, they can be by flow cytometry, and then even look not only for the PNH clone but for the LGL clone. So the TCR gene rearrangements to detect clonal T large granular leukemia is in this situation to exclude the STAT3 mutation. So in adults, we can even rule out abnormal clones like the PNH clone, the TLGL clone, and the MDS cytogenetic clone with the metaphase cytogenetics and cytofish. So so we can for children the Fanconi anemia by using the DEB test or the MMC induced chromosomal breakage can be is done, and even for the telomere gene mutation analysis, we can go for the leukocyte telomere length, peripheral leukocyte telomere length, or flow cytometry, flow fish or multiplex PCR is done. The very short telomeres far below the first percentile for age are indicative of dyskeratosis congenita. So the short telomeres that I mentioned here, the ones that is since they mentioned that the telomere length can be less specific in adult onset because it may be there with TERT mutations, and short may also occur with acquired aplastic anemia with reduced stem cell reserve. So another thing that you mentioned in Hoffman is that patients with very short telomeres, that is far below the first percentile for age, are indicative of dyskeratosis congenita. So if we do the telomere length, most if it is reduced, it may be because of acquired aplastic anemia also. But for inherited and dyskeratosis congenita, then the telomeres will be very short. That is far below the first percentile for age. So this would also help us exclude. They will be far below the first percentile for um, for age in case of dyskeratosis congenita. So, and when we can resume again, we'll go over the causes for hypocellular marrow, how the bone marrow findings, what are the bone marrow findings, and how we differentiate the different alternative causes for aplastic anemia based on other upon the bone marrow findings. How we the cause of aplastic anemia based on bone marrow findings for hypocellular MDS, and look for NHL, HL, myelofibrosis, and rule out all these causes for um, hypocellular marrow. So we'll take a short break here, and we'll join again in about 1 minute with the difference between we'll go over the diagnostic investigations for pediatric age group and compare the bone marrow findings for adult aplastic versus other causes of hypocellular bone marrow.